Module Overview. Pressure ulcers, also known as bed sores or decubitus ulcers, are injuries to the skin and underlying tissues caused by prolonged pressure on the skin. They are most common in individuals who are bedridden, immobile, or confined to a wheelchair. Preventing pressure ulcers and maintaining skin integrity is a foundational duty of any bedside care provider. This module delves deeply into the biological, mechanical, procedural, and ethical frameworks involved in skin care and ulcer prevention. It teaches you how to recognize risk, intervene early, and document with clinical accuracy, meeting standards from regulatory bodies like the Joint Commission, TJC, OSHA, and ISO 9001 in healthcare environments. Understanding skin anatomy and function in bedridden patients. The skin is the largest organ, composed of epidermis, dermis, and subcutaneous layers. Functions include protection from pathogens, temperature regulation, sensory perception, fluid balance, and vitamin D synthesis. In immobile patients, skin is more susceptible to breakdown due to reduced circulation, constant pressure over bony prominences, e.g., sacrum, heels, moisture exposure from sweat, urine, or wounds, friction and shear from improper repositioning. What are pressure ulcers? Pressure ulcers are localized injuries, usually over bony areas like the sacrum, hips, elbows, and heels. Risk increases in elderly individuals, malnourished patients, diabetics, or those with poor circulation, sedated or unconscious patients. The National Pressure Injury Advisory Panel, NPIAP, classifies ulcers into 4 stages. Stage description: I. Non-blanchable erythema of intact skin. 2. Partial thickness, skin loss with exposed dermis. 3. Full thickness skin loss. 4. Full thickness skin and tissue loss with exposed bone/muscle. Causes and risk factors. Factor description: pressure from immobility, poor mattress, or prolonged sitting. Friction skin rubbing against sheets or clothing. Shear skin stays in place while the skeleton moves, e.g., when the bed is raised. Moisture from sweat, incontinence or wound drainage. Nutrition: protein, zinc, and vitamin C deficiencies inhibit skin repair. Sensory loss, paralysis, or sedation prevents awareness of pain or discomfort. Early signs and monitoring techniques. Early detection saves lives and reduces cost of treatment. Key signs: redness that doesn't blanch when touched, warm or cool areas on the skin, localized swelling, skin breakdown or blisters, reports of burning, tingling, or discomfort. Monitoring tools: Braden scale for pressure, sore risk skin inspection checklists, moisture assessment charts. Prevention strategies. Prevention is more effective and affordable than treatment. Repositioning techniques: every 2 hours in bed, every 15 to 30 minutes in wheelchairs. Use turning schedules and charts. Support surfaces: pressure relieving mattresses, overlays or cushions. Heel protectors and elbow pads. Hygiene and moisture control: clean urine feces immediately. Use barrier creams or ointments. Keep skin clean, dry, and moisturized. Nutrition and hydration: encourage high protein, high calorie meals. Offer zinc, vitamin C, and omega-3 supplements, if approved by healthcare provider. Maintain adequate fluid intake. Mobility enhancement: encourage active and passive range of motion exercises. Use sliding sheets to reduce friction. Use proper lifting techniques. Dressing and wound care basics. Support role: caregivers do not perform dressing changes unless trained and certified. However, they must recognize signs of infection, odor, pus, fever, increased pain. Observe dressing integrity. Notify licensed professionals if dressing is soaked or displaced. Document wound observations accurately. Emotional, legal, and ethical considerations. Pressure ulcers are sometimes viewed as indicators of neglect. Legal actions can be taken if there is no documented repositioning, wound development is ignored, records are falsified or incomplete. Ethical obligations: respect dignity, never expose unnecessarily. Act promptly on signs of discomfort. Report abuse, neglect, or incompetence. Record keeping and communication. Documentation should include date, time of skin checks, repositioning logs, observations of redness or breakdown, fluid intake, nutritional logs, reports to registered nurses or physicians. Accurate communication prevents escalation and supports multidisciplinary care.